السلام عليكم.
عليكم السلام ورحمة الله. هلا عبد الرحمن.
Hello وسهلا. So I think today we'll start our academic activity. ما أدري first one دكتور محمد بابجي.
ايوه اهلا.
هلا كيف حالك؟
الله يخليك سلام.
So I think you're ready. You want to start now ولا يعني after 5 minutes ولا
105 will start إن شاء الله.
اوكي
105
ان شاء الله.
خلاص تمام.
Assalamu alaikum. Shall we start or?
Yeah, the mic is yours.
Okay. Assalamu alaikum everybody. Inshallah, during my presentation, I'm going to speak about the trauma to the great vessels. Is my slide clear or apparent to you?
Yeah.
Okay.
All clear.
Thank you. So as an introduction, a blunt thoracic aortic injury is considered the most common thoracic vascular injury. And it is the second leading cause of death in the United States from a non-penetrating trauma. And it's been reported that around 75 to 90% of cases, death occurs at the accident scene. And typically in those with multiple injuries, more than 4 serious injuries in addition to the aortic transection. Some data suggest that approximately 4% of patients die during the transport from the scene, and an additional 19% die during the initial trauma evaluation. This table showing the groups of patients with injury to thoracic aorta, and those who die at the scene or dying at the scene mostly due to exsanguinating bleeding with complete transection of the aorta, and usually those diagnosis is less than 60 minutes, and they do not make it to the hospital. The group of patients who are unstable during the transport, most of the time they will die within 6 hours, and the mortality is reaching up to 96%. And most common cause of death is multisystem trauma. Those who arrive stable at the hospital, the most common cause of death is CNS injuries, and the mortality rate among those group or this group is around 5 to 30%. So the injury to the thoracic great vessel most of the time can occur due to penetrating or blunt trauma, with majority, more than 90% of great vessel injury are due to penetrating trauma or therapeutic misadventure, iatrogenic injuries. The most commonly affected thoracic vessel is the descending thoracic aorta, but other vessels are susceptible to blunt traumatic injury, and this include innominate arteries, pulmonary veins, vena cava, ascending aorta, and the other aortic arch branches. And it's been reported that the proximal descending thoracic aorta represents around 54 to 65% of injuries, followed by the transverse aortic arch and the ascending aorta with around 10 to 14%, and then the mid or distal descending aorta with 12%, and the remaining of multiple sites of injuries. The mechanism of blunt great vessel injury can include one of the following physiological mechanism: either a shearing force caused by a relative mobility of a portion of the vessel adjacent to a fixed portion, and this is clearly apparent in case of proximal descending thoracic aorta, where it's fixed with the ligamentum arteriosum. Other mechanisms include the compression of the vessel between opponent structures, as well as abrupt or profound intranumeral hypertension during a traumatic event. The areas of attachment, like the pericardial attachment of the pulmonary veins and vena cava, and the fix of the descending thoracic aorta to the ligamentum arteriosum and the diaphragm, all of these enhance the susceptibility to blunt rupture by the first mechanism, the shearing force, due to deceleration, rapid deceleration. The classification of blunt aortic injury, it can be, there are multiple classification systems. Some of them classifying as a partial thickness injury, and this is representing like a traumatic true aneurysm with histologically similar to intimal tear, or a full thickness injury that representing a traumatic false aneurysm, and it's equivalent to a ruptured aortic aneurysm that is contained by a surrounding tissue. When using the terminology, the term aortic transection and blunt aortic rupture should use only when describing specific injuries, meaning a full thickening laceration involving either the entire, that means a transection, or a partial circumference, that means aortic rupture. And the term aortic blunt aortic injury is probably the most accurate descriptive term. Aziz Abdi et al. Has proposed another classification description for the blunt aortic injuries, and divided it into 4 groups: the intimal tear, intramural hematoma, pseudoaneurysm, and the rupture. And this picture showing the same classification, with the grade 1 is just an intimal tear, and the grade 2 representing intramural hematoma, grade 3 is pseudoaneurysm with abnormal contour of the aortic wall, and grade 4 with full thickness rupture and exsanguination of a blood. Another classification system proposed by Starnes et al. And in this classification system, they divided the aortic injury based on the external aortic contour. whether an abnormality of the external aortic contour is absent or present. If it's absent, then it's subdivided into two types, either an intimal tear less than 10 millimeter or a large intimal flap more than 10 millimeter. If there is an abnormality of the external aortic contour present, then it's being divided to either of these two types, either a pseudoaneurysm or a full rupture. And it's almost similar, but it's a different classification system. An important concept, another important concept to keep in mind when dealing with a patient with traumatic aortic injury is the zonal division of the thoracic aorta. And this is extremely important when utilizing endovascular repair, because it's classifying or dividing the aorta based on the proximal and the distal landing zone. So there are almost 11 zones of the aorta, but for the thoracic aorta, it's divided into 4 or 5 zones, with zone 0 from the sinotubular junction till the innominate artery, with zone 1 from the innominate artery to just proximal to the left common carotid, and zone 2 from left common carotid to left subclavian, and zone 3 just 2 centimeters from the subclavian till the proximal part of the descending thoracic aorta, and the zone for the from the mid to distal part of the descending thoracic aorta, and then the remaining for the abdominal and bifurcation of the aorta. So the management of a patient with a traumatic aortic injury, the initial evaluation and management start actually as before arriving to the hospital, and the improvement of pre-hospital management has a great impact in improving in the improvement of the survival of such a group of patients. The pre-hospital management, the paramedic should focus on appropriate resuscitation, and judges administration of intravenous fluid is an important part of resuscitation, as it's being proposed that patients with acute injury to thoracic great vessel, the excessive fluid resuscitation in order to increase the blood pressure to normal or supranormal levels has a worse impact on the mortality and the post-operative complication. Once the patient arrives to the hospital, a patient should go through the standard protocol of ATLS approach as any trauma patient, regardless of whether an aortic disruption is suspected or not. And this includes the primary survey, secondary survey with the adjunct investigation and imaging techniques. With regard to aortic injuries, first step in diagnosing a blunt traumatic aortic injuries is identifying those groups at risk. And in patient with penetrating trauma to the thoracic cavity, especially in the area between the two mid-clavicular lines, those at higher risk of having a thoracic vascular injury. Other point to consider with regard to the penetrating trauma is the type of penetrating object, the length of the object, the firearm type, number of rounds, and other things. All of these will give suggestion of a presence of an aortic injury of other thoracic vascular injury. For blunt traumatic injuries, the pattern of injury is of paramount. For example, the vehicle collision, the extent of the damage, the location of the damage, all these will be suggestive of presence of thoracic vascular damage. Other findings during primary and secondary survey of physical examination include the patient of whom hypotensive, especially if there is a variation in blood pressure measurement between upper extremity, for example, unequal blood pressure or pulses in the upper extremities goes with innominate or subclavian artery, or if there is differences between upper and lower extremities suggestive of pseudocoarctation syndrome. External evidence of a major chest trauma, like a steering wheel imprint, hoof print on the chest, and expanding hematoma at the thoracic outlet, intrascapular murmur, and a palpable fracture of the sternum. All of these are suggestive of thoracic vascular injury. This table showing these clues like in history, a motor vehicle crash with a high speed, no seat belt, ejection from a vehicle, broken steering wheel, fall from a height more than 3 meters, crash or cave-in injuries. All of these are suggestive of a high mechanism that carries a high risk of thoracic vascular injury. Physical finding, as we said, hemodynamic instability, sternum fracture, rib fracture, clavicular fracture, especially the first rib fracture and clavicular fracture comes with a subclavian and sometimes left carotid injuries. Steering wheel imprint on the chest, back pain, unequal extremity pressure, and paraplegia or paraparesis. As part of the adjuvant assessment of primary survey as a chest X-ray, and as a routine, all trauma patients should have an AB supine chest radiograph obtained as part of the initial evaluation. And a finding of widened mediastinum, hemothorax, and the transient hemodynamic instability on arrival appears to be a predictive of early in-hospital death from a blunt traumatic aortic injury. And there are around 15 signs in chest X-ray have been associated with aortic rupture. However, none of these signs have sufficient sensitivity or sensitivity to rule out aortic injury, meaning their absence or the absence of these signs does not rule out the aortic injury or thoracic vascular injury, but a presence of these signs, of some of it, is highly suggestive and raises suspicion of thoracic vascular injury. This chest X-ray, the one on the left of the screen, showing a widened mediastinum with a deviation of the trachea, and clearly showing the deviation of the NG tube and the esophagus due to an injury to the descending thoracic aorta. And this another chest X-ray showing a foreign body with the penetrating injury of the ascending aorta. These two tables showing the finding, the 15 findings that we just mentioned earlier, that's highly suggestive of thoracic vascular injury, which include a widened mediastinum, more than 8 centimeters, a ratio of mediastinum to chest width of more than 25%, tracheal shift to the patient's right, blurred aortic contour, irregularity or loss of the aortic knob, left apical cap, depression of the left main bronchus, wide paraspinal lines, rib fracture, clavicular fracture, pulmonary contusion, thoracic spine fractures. And this one is mentioning the same findings, but just in a different arrangement. So further in initial evaluation and management is the important concept of fluid administration and resuscitation. The treatment of a severe shock should start almost always with blood transfusion and rapid infusion of excessive volume, either crystalloid or colloid, prior to operation may increase the blood pressure to a point that can dislodge the perivascular clots and lead to exsanguinating hemorrhage. And hence the principle of permissive hypotension with accepting a systolic blood pressure of around 90 and limiting fluid administration until achieving the operative control of bleeding is an important principle in trauma management. And a military guideline that is somehow widely accepted by trauma surgeon is stating that a conscious patient with a radial pulse with a palpable radial pulse is not resuscitated until the time of operative vascular control. As it's been shown that preoperative resuscitation with is increasing the post-operative respiratory complication and also contribute to increased mortality when compared to fluid restriction. Chest tube insertion, when there is an evidence of hemothorax and chest X-ray, chest tube should be placed and connected, if available, to a collecting system for auto transfusion. An output of more than 1,500 in the first 15 minutes, or an ongoing bleeding of more than 200 to 250 is an indication for emergent or urgent ED thoracotomy. The indication for ED thoracotomy is in patient with hemodynamic instability or hemodynamic collapse, and or a patient with high output of chest drain. Those kind of patients may be indicated for ED thoracotomy, and this will aid in identifying and controlling any of thoracic vascular injury. For example, a subclavian vessel injury can be controlled by intrapleural backing, clamping the thoracic apex, or thoracic apex, or insertion of intravascular balloon catheter. For aortic injury, it can be controlled with partial occluding clamp or aortic clamp. Pulmonary or major hemorrhage from pulmonary hilum can be managed by cross-clamp the entire hilum proximal to the injury, or twisting of the lung 180 degree after releasing the inferior pulmonary ligament. So after the primary and secondary survey, other investigation to diagnose thoracic vascular injury should be utilized, especially if high suspicion is present. And computed tomography is an essential modality for diagnosing such a pathology. Especially nowadays, almost all trauma patients have, or with high mechanism of trauma, usually they will go through a band CT to look for variant injuries. And it's becoming the screening tool of choice at most medical institutes to detect traumatic aortic rupture. And this is due to its availability, the speed, and the ease of interpretation, in addition to a high sensitivities and a negative predictive value nearing 100%. A finding on the CTs that suggests of aortic injury include filling defect, contrast, extravasation, intimal flap, periaortic hematoma, pseudoaneurysm, or mural thrombi. This is a sagittal view of a CT scan of a patient showing an aneurysm at the proximal part of the descending thoracic aorta, a traumatic aneurysm. And this is another CT with a 3D reconstruction showing also a tear and pseudo coarctation of the descending thoracic aorta. Other modalities like transesophageal echo, it's becoming a valuable tool due to its ability to image the entire descending aorta with a portion of the ascending aortic arch and its portability. And most of the time, it's been utilized in unstable trauma patients whom requiring emergent laparotomy. For those kind of patients, the TE can be utilized intraoperatively to evaluate the descending aorta for any evidence of rupture, such as a mural flap, thickened vessel wall concerning a mural thrombus. A disadvantage of a TEE is that it's it is an operator dependent, and this will affect its sensitivity. And especially in a trauma patient, it has some of contraindications that might preclude its utilization, such as injury to cervical spine, oropharynx, esophagus, or maxillofacial structures. Orthography. The role of orthography in evaluating blunt thoracic injuries was was the role of arterography in evaluating blunt thoracic injuries was firmly established prior to the advent of a non-invasive imaging technique, and it may be still considered as the gold standard. As in experience has been shown that sensitivity and specificity of this modality approaching 100%, but sometimes the negative arterogram may convey a false sense of security, especially in cases of laceration has sealed off temporarily, or if the column of the aortic contrast overlies a small area of extravasation, such as this image, as we can see in the chest X-ray, does not reveal any concern about any aortic injury. And the aortogram in the first three images, image B, C, and D, does not show any vascular defect or injury in the aortic arch, ascending aorta, or the descending segment of the aorta. But in the last image of the digital subtraction, with a different view and different technique of arterogram, it reveals 2 points of injuries, one anterior at the level of origin of the innominate artery, and the other one at the proximal arch posteriorly. So once the diagnosis of thoracic vascular injury has been established, then decision should be made either to repair or to go for expectant management. For unstable patients, they should bypass the diagnostic imaging, the detailed diagnostic imaging, and they should be taken immediately to the operating room. And as we said, during damage control surgery, TE can be utilized to diagnose aortic injuries. Once, even if aortic injury has been diagnosed by TE during the damage control surgery, a repair should not be attempted at that time. And patients should be stabilized first. And starting the anti-impulse therapy with beta blocker should be initiated to minimize the aortic wall stress. For hemodynamically stable patients diagnosed with a blunt aortic injury and lacking of severe other injuries requiring intervention, those kind of patients should warrant immediate repair. And the treatment of any non-life-threatening injury other than the aortic should be delayed until the definitive aortic repair. Patients with other injuries that need immediate intervention, like intraperitoneal, retroperitoneal hemorrhage, or intracranial bleeding, that causing a mass effect, those kind of patients should be managed with aggressive anti-impulse therapy to minimize the risk of aortic rupture, and the intervention for aortic injury should be delayed until the control of other source of other injuries. And the goal of anti-impulse therapy is to maintain the systolic blood pressure less than 120 millimeter mercury, or a mean arterial pressure less than 80. And patients should be monitored by a TE or a routine CT scan during the delayed management period to assess for any expanding pseudoaneurysm, and to time to decide the appropriate time for intervention. And it's been reported that mortality rate of patients awaiting aortic repair has ranged from 30 to 50%, but most of the deaths were not related to the aortic injury. And in-hospital aortic rupture rate has been reduced through aggressive beta blockade without adverse affecting the outcome of associated injury. And all of these findings suggest the safety of delayed management of such aortic injuries. So management strategies will go through each segment of the aorta and other vascular injury one by one. And it's almost always two types, either an open surgical repair or endovascular repair. We'll go through all of these in specific. For the ascending aorta, patients with a blunt injury to the ascending aorta rarely survive to transport to the hospital. And a penetrating injury is extremely uncommon in ascending aorta, with the survival rate approaching 50% for those who arrive stable at the trauma center. The mechanism of injury to the ascending aorta include the transmission of the force through the cavity from the blunt trauma, which causing a torsion of the ascending aorta and disruption of the wall with associated shearing effect on the heart. Another mechanism include, which is the water hammer effect, and it's described as when an aortic occlusion at the diaphragmatic level occurs, a high impact and high pressure wave is transmitted backward and reflected on the aortic arch and ascending aorta, resulting in intimal tear and aortic wall injury. The repair for ascending aortic injury is usually pseudoaneurysm of the ascending aorta should be repaired using a cardiopulmonary bypass. And depending on the nature and the extent of the injury, repair may be conducted by primary repair, patch angioplasty, or prosthetic replacement of the aortic segment. And if the sinuses of Valsalva or aortic valve is involved, full root replacement with valve prosthesis may be implemented as well. Using a deep hypothermic circle rest sometimes is required, especially if proximal and distal control cannot be obtained, or if the pseudoaneurysm is extending to the proximal aortic arch. The decision for delay management in such a group of patients may be considered if they are hemodynamically stable and they have other injuries at high risk of bleeding, like intracranial bleeding. And as I said, the decision of delay depends on the nature of the ascending aortic injury. And this injury should be discrete lesion without evidence of circumferential involvement or compromise of adjacent structure. Otherwise, those kind of patients should not go for delayed approach and should be managed immediately. And it is essential to maintain the arterial pressure less than 80 and the cerebral perfusion pressure greater than 50. With the conservative management accomplished with regular assessment of aortic lesion with a serial CT scan to assess for any expansion of the pseudoaneurysm. The rule of endovascular repair or TVAR for ascending aorta has not been evaluated or reported thoroughly in the literature, and there are limited or no commercially available endovascular devices designed to treat the ascending aorta. In addition to the complex pathology with and anatomy of the ascending aorta with its proximity to the aortic valve and coronary arteries, all of these makes it challenging to obtain a will sealing and fixing and fixation within the proximal landing zone. For that reason, so far the management of ascending aortic injuries managed with median sternotomy and cardiopulmonary bypass. For aortic arch branches, starting with the innominate artery, and it is considered the second most common site of thoracic vascular injury after blunt trauma following the descending thoracic or proximal descending thoracic injury. And most common finding of innominate artery injury is a disruption of the intima and the media with pseudoaneurysm formation. With reports that showed majority of cases, the injury is involving the proximal part of the vessel. The mechanism by which a innominate artery rupture occurs after blunt trauma is resulting from an anteroposterior compression of the mediastinum between the sternum and the vertebrae, displacing the heart posteriorly and to the left. And this will cause a tension on the aortic arch and its branching vessel. Other mechanisms include hyperextension of the cervical spine with a head torsion or rotation, providing additional tension on the right carotid artery, and that will be transmitted to the innominate artery. The repair for innominate artery can be either surgical or endovascular. For surgical repair, the innominate artery rupture usually performed the approach usually performed by or repair performed by prosthetic aortic innominate bypass graft from the aortic arch to a healthy distal vessel. And the approach is through full or upper median sternotomy with incision extended to the right anterior border of the right sternocleidomastoid as necessary to get better exposure and good control for proximal and distal. And the entire length of the innominate artery should be mobilized to achieve the distal control, when pericardium should be open to gain a proximal control at the level of the aortic arch. Then a distal end-to-end anastomosis may involve only the innominate artery, or if the lesion is extending beyond the bifurcation, a wide graft with anastomosis to subclavian and common carotid artery should be established. This is an orthogram showing a proximal innominate artery pseudoaneurysm after a blunt trauma. And this diagram showing the surgical technique for innominate vascular injury, in which establishing a proximal anastomosis to the side of the aorta with interside anastomosis, and then distally attached to the distal graft to the distal innominate artery before the bifurcation. If the injury is extending beyond the bifurcation, then a wide graft to each segment should be established. And then the proximal part of the innominate artery should be oversewn with the pledge stitches. For a stable patient with either a blunt or penetrating injury to the innominate artery, most of the time they benefit from endovascular repair with a stent graft without any reported complication. An important technical consideration for endovascular repair of innominate injury is to avoid the occlusion of the right common carotid artery with the stent at the distal landing zone. In some cases, to have such adequate landing zone away from compromising the carotid artery is difficult, and if it's necessary to compromise the right common carotid artery, a subclavian carotid bypass should be performed before the deployment of the stent. For the left carotid artery, the mechanism of left carotid artery injury, including a stretching injury from a rapid deceleration producing an intimal tear and subsequent dissection, or due to a hyperflexion of the neck to cause compromise between the mandible and cervical spine, basilar skull fracture transecting the artery, or strangulation injuries. And management of such patient, usually the important part of management is to be directed to preventing cerebral ischemia from the lumen narrowing due to a thrombus formation. And a surgical intervention should be weighed against the observation and the risk of anticoagulation, as such patient is having high risk of bleeding due to other associated injuries. And in the opposite, we have the risk of thrombus formation. So operative intervention is indicated in cases of pseudoaneurysm formation, but the decision to delay the intervention should be weighed on an individual basis. Arterial repair may be accomplished by primary repair interposition graft with saphenous or prosthetic material. For endovascular repair of left common carotid, the risk of embolization should be considered, and many advocate for delaying the stenting in order to minimize the risk of embolization. And if a decision was to delay the management, anticoagulation should be started, and to maintain PTT time between 40 to 50 has been accepted in minimizing the risk of thrombosis and not increasing the risk of bleeding. The third aortic arch branch is the subclavian artery, and the blunt subclavian artery more common in the middle and the third and the distal third of the artery, and it's theorized that it's resultant from a fracture of the first rib, and the subclavian artery then is pinched between the first rib and the clavicle. Other theory is that the abrupt deceleration of this shoulder due to the seat belt will result in shearing injury on the subclavian artery. It's been reported that mortality rate of subclavian injuries as high as to 30%. And this is a result of difficult control of hemorrhage due to the anatomical position of the vessel. And because of the close proximity of the subclavian artery to other vital structures like esophagus, subclavian vein, brachial plexus, other morbidities are very high with a rate of 40%. The approach of surgical repair for such an injury can be achieved via different approaches: median sternotomy, limited sternotomy, supra or infraclavicular, thoracotomy, or a combination of these approaches depending on the location of the injury. And once the approach has been established and proximal and distal control has been achieved, the damaged segment of the vessel is excised, and the arterial reconstruction is accomplished with interposition graft using either a savinous vein or, more commonly, the prosthetic material. For a critically ill patient, a ligation of the subclavian artery may be just performed, and the short-term morbidity of the affected limb is being accepted. The endovascular repair of subclavian artery injuries is relatively well described in the literature in comparison to other artery vessel and the ascending aorta. And the stents have been effectively treated if treating the pseudoaneurysm, lacerations, AV fistulas, complete transection of the subclavian artery with reduced incidence of brachial plexus injury. Important part of management post stent placement is antiplatelet therapy, and that is consisted of Plavix for 3 months, and then followed by a lifelong aspirin therapy. The last segment of aorta is the of thoracic aorta, the descending thoracic aorta, and it is the most common location, as we said, for a blunt aortic injury. With a traumatic aortic disruption occurs most commonly at the isthmus, and autopsy series identified more than 54% of patients have an injury at this site. The traumatic aortic disruption occurs due to a motor vehicle accident for a driver or a passenger, or a pedestrian patient. Other group of patients might sustain such an injury, those who has ejected from a vehicle, and this group of patients has a twice risk of sustaining traumatic aortic injury, with studies that showed seatbelt wearing decreased the risk by 4-fold. Other mechanisms of injury, like falling from a significant height, crash injuries, airplane accidents, all result in descending thoracic aortic injury. And the pathophysiology of descending thoracic injury has multiple theories, with 2 common theories is the whiplash theory, which proposing that a combination of traction, torsion, shearing, and bursting forces all interact, and owing to differential deceleration of the tissue within the mediastinum, and thus resulting in adequate stress to rupture the aorta at the isthmus level, which is the fixed part of the aorta. And as I said, the ligamentum arteriosum, the left main stem bronchus, and paired intercostal arches all limit the mobility of the descending aorta. The other theory is the osseous pinch mechanism, during which the anterior thoracic osseous structure, meaning manubrium, first rib, the clavicular head, all of which rotate posteriorly and inferiorly, impacting on the vertebral column and pinching the aortic isthmus and proximal descending thoracic aorta, causing a shearing of the aorta. The operative strategy or management strategy for descending thoracic injury, it's been traditionally undergone open repair with interposition graft placement, and this approach has proved to be safe, effective, and durable, and that's why it has been established as the standard approach before. But it showed a mortality of around 20% and the morbidity rate of around 14%, and most of the time related to the spinal cord ischemia. With the development and improvement of endovascular therapy, many studies have shown favorability of endovascular repair over operative technique. The rescue trial, which reported on a 50 patient with a blunt thoracic aortic injury who underwent TEVAR and showed that all-cause mortality within 1 year was 12%, and there were no conversion to open repair. There were no device-related adverse event, and this demonstrated the superiority or favorability of a midterm outcome in the treatment of blunt thoracic aortic injury. If a patient was decided to go for open repair, major controversy with this approach is the spinal cord protection. And even when utilizing adjuvant reperfusion techniques, some of preoperative preparation that required to monitor the somatosensory potential, evoked potential, on providing the lumbar cerebrospinal fluid drainage, achieving epidural cooling, all are not available in the trauma setting, in the acute setting, in contrast to an aneurysm patient. Another obstacle or challenge is the systemic heparinization, which is posing a significant risk in a trauma patient, and this will limit the utilization of full bypass or partial bypass, except if you are using circuit bonded heparin bonded circuits. Anyhow, utilizing some of the approaches like partial left heart bypass or full bypass will minimize the incidence of spinal cord ischemia, especially with the left heart bypass. It's beneficial in unloading the left heart, maintaining lower body perfusion, allowing a rapid infusion, and controlling the intravascular volume. And this can be achieved by cannulating the left atrium through the left lower pulmonary vein, and then the arterial cannulation to the distal descending aorta or the femoral artery. And this table showing the incidence of post-operative paraplegia after a surgical repair, and it's showing the least risk or the least percentage of paraplegia with the partial bypass or cardiopulmonary bypass. The endovascular repair for descending thoracic injury is becoming the common approach for management of such an injuries, and the safety and efficacy of this approach has been demonstrated, and it's considered the method of treatment. The theoretical advantage of stent grafting include avoidance of thoracotomy and well-lung ventilation, especially if the patient has associated lung contusion. Systemic effect, avoiding the systemic effect of cardiopulmonary bypass and the effect of anticoagulation, avoiding the aortic cross clamp, and avoiding the spinal cord ischemia, all of which should decrease the perioperative mortality and morbidity. In patients with a stable aortic injury, grade 2 or 3, the timing of intervention is usually dictated by the severity of other associated injuries. And if patient has significant intra-abdominal or cerebral hemorrhage, a delayed management with the proper anti-impulse control should be utilized until life-threatening injuries being treated, and it's been shown to be safe and beneficial. In patient without other serious injuries, the trend has been to treat grade 2 or 3 injuries within 24 hours of admission to avoid the progression to grade 4 injury and the potential deleterious effect of aggressive anti-impulse therapy. An important anatomical consideration must be addressed when deciding whether a patient is candidate for TEVAR of a blunt traumatic aortic intersection is that the proximal landing zone, there should be at least 1.5 centimeter of a landing zone away from the left subclavian artery in order to achieve a reliable seal and avoid the risk of endoleak or the risk of occluding the left subclavian and the risk of left arm ischemia. But it's in case of rare cases of in which you have to compromise the left arm ischemia, elective carotid to subclavian bypass may be performed, and many studies showing that there is no difference in arm ischemia if you cover or uncover the left subclavian artery due to the collateral present. Patients who will undergo TEVAR for traumatic aortic disruption should be positioned in a hybrid operating room or a conventional room with a fluoroscopic capability, just in case a conversion to open repair is needed, and should undergo general endotracheal intubation with general anesthesia. Even though the conversion to open repair is rare, but it's been occurred. The outcome of the endovascular repair, it did decrease the operating time, diminish the physiological derangement and hypothermia, decrease the transfusion rate, and result in a shorter ICU time and overall hospital stay. And all have been documented in a series directly comparing the open endovascular repair of a blunt traumatic injury and the procedure-related paraplegia and mortality rate markedly reduced to around 0%. Other major vascular injury include the pulmonary artery injury. The mortality of pulmonary of injury to the central pulmonary arteries or vein are greater than 70%, where the intrapericardial pulmonary artery are best approached via the median sternotomy for control. And if there is only an anterior injury, it can be repaired primarily without any adjunct. However, if there is a posterior injury, then cardiopulmonary bypass should be utilized. If the injury is involving the distal main pulmonary artery with a massive hemothorax, then this part of a hilar injury should have a rapid pneumonectomy using an M-block stapling, and this could be a life-saving maneuver. The use of hilar clamp can control the hemorrhage as well as preventing the air embolism as just as a temporizing measure. With regard to the vena cava, isolated injury to the intrapericardial inferior or superior vena cava is infrequently reported, and injury at either location has an incidence of associated injury and mortality rate greater than 60%. Injury to the intrapericardial inferior vena cava causes a hemopericardium and cardiac tamponade, and this will be evident during the initial evaluation. The management of such a patient usually is surgically, and exposure of the posterior intrapericardial inferior vena cava is extremely difficult unless patient is placed on bypass with the inferior cannula inserted via the groin into the abdominal IVC. And the injury then exposed by right atriotomy and the intracaval balloon occlusion to prevent air entering to the cannula. And the repair usually achieved from the inside, from inside the cava via the right atrium. With regard to injuries to the superior vena cava, they are repaired by lateral venography For complex injuries, usually PTFE patch or a Dacron interposition tube graft can be used. This is all. If you have any question, these are my references.
يعطيك العافية يا دكتور.
الله يعافيك إن شاء الله.
ثانك يو محمد، يعطيك العافية. عبد الرحمن موجود؟
الله يعافيك أحمد.
Okay, so I think Abdurrahman is out. So we're gonna have 10 minutes, then we'll resume our lecture.
Here I am, almost $10,000 from them. Surrounded by empty water. Finite on the board. You can't be a self. We are not together. But we each stand alone.
Any changes. Mm-hmm. Once again, messages of Christmas greeting have been exchanged around the world, carried upon the invisible wings. And hearing those of my husband. From all the members of your family gathered here today, our very best wishes go to you on board the plane. Very large, united family is waiting. And will always be waiting. Wherever you go.
دكتور زياد.
ايوه.
Let's start please.
Okay.
بسم الله.
Hello everyone. My name is Ziad Al-Sharif. I'm R1 cardiac surgery resident at King Saud University. Today I will present to you Bulmario Embolism and Thromboendartectomy, inshallah. These are our objective. I will start with introduction, then I will talk about prevalence, then I will explain the basic pathophysiology and list the current risk factor for BE. Then I will describe the clinical presentation and explain the diagnostic evaluation. Then we will have small talk about DVT and explain the current treatment of BE. Finally, I will talk about pulmonary thromboendartectomy, inshallah.
First, pulmonary embolism occurs when a thrombus in other region of the body embolize to the pulmonary vascular tree, and blood flow distal to the embolus is obstructed. Massive type result from an acute right ventricular failure and death typically within 2 hours, usually undiscovered until autopsy. It is estimated that 95% of pulmonary embolism arise from sources, and it is a complication of DVT. Sources of the emboli can be from deep vein thrombosis or other veins such as superficial femoral vein. In deep venous thrombosis, lower extremity is the most common, while upper extremity is very rare. Other sources of emboli include fat, amniotic fluid, air, or septic emboli in IV drug abuser. Pulmonary embolism causes over 100,000 deaths each year, and about 10% of DVTs are associated with pulmonary embolism. Of these, about 10% are fatal. Pathophysiology can be identified as blocking abortion of pulmonary vascularity, leading to increased pulmonary vascular resistance, and pulmonary artery pressure, which increase in the right ventricular pressure. And decreased filling of left ventricular causes decreased CO, and hypoxia will stimulate vasoconstriction and increase the pulmonary artery pressure. Decreased blood flow in some area of the lung, leading to hyperventilation and creating dead space in the lung. Risk factors include DVT and history of DVT or BE, cancer, oral contraceptive use, obesity, sedentary lifestyle, pregnancy, venous catheters, immobility, IV drug abuser, underlying disease like MI, congestive heart failure, CVA, COPD, major trauma and major surgery, especially pelvic surgery, nephrotic syndrome due to loss of antithrombin 3, or autoimmune disease or hypercoagulability state. Most patients who present with pulmonary embolism will have one of these risk factors. As the number of risk factors increases, the risk also increase. Signs and symptoms will vary from the degree, vary with the degree of the pulmonary vascular occlusion, and most often it's clinically silent. Larger the embolus, the greater the clinical sign and symptoms. Symptoms include dyspnea, which is the most common, pleuritic chest pain, cough, hemoptysis, non-pleuritic chest pain, syncope, enlarged BE, anxiety, and unilateral leg pain for DVT. Signs include tachypnea, tachycardia, diaphoresis, lower extremity edema, cyanosis, decreased breathing, rales, adding sound, dullness on percussion, fever, hypotension. And most sensitive symptoms are tachypnea and tachycardia. 95% of patients will have at least one of the following, either dyspnea, tachypnea, or pleuritic chest pain. If these findings are absent and the patient is without risk factor, the diagnosis of pulmonary embolism is unlikely. In the diagnosis, you should start with history to identify the risk factor and physical examination to identify any signs. Then to initial tests like chest X-ray, and usually normal, and it is used to exclude alternative diagnosis. In ABG, will show low O2 and CO2, and will show respiratory alkalosis. ECG will show sinus tachycardia, anterior T-wave inversion, ST segment and T-wave changes, and rarely right bundle branch block. To confirm test which divide to two part, which high clinical suspicion or low clinical suspicion. In high clinical suspicion, first we have to do CT angiogram. It will visualize the pulmonary vessel and allow us to see the clot. If the clot is present, it will confirm the diagnosis of BE. it is contraindicated in renal insufficiency. It is considered non-invasive test with a high degree of sensitivity and specificity, and has 99 to 100% negative predictive value. Second, we have VQ scan, usually used when CT angiogram is contraindicated. If normal, we'll exclude BE. If show high probability, then confirm diagnosis of BE. If low or intermediate probability, we will do lower extremity duplex ultrasound. Third test is lower extremity double ultrasound, and it is used when VQ show low or intermediate probability. Last one is Belmury Angiography, and it is used when all above are equifocal. If low clinical suspicion, we'll have to do the D-dimer. If positive, we will start the steps of high clinical suspicion. If negative, we'll exclude the diagnosis of BE. In the diagnosis, the gold standard is Belmury Angiography, but not available on all institutions, and it is invasive with associated risk and complication. In MI and pneumonia and congestive heart failure, the dimer will be elevated. Treatment, you should begin with ABC with close monitoring, then start oxygen and fluid as patient may have signs of hypoxia and advance to state of shock. Anticoagulation with the use of heparin has been the mainstay of treatment. Heparin bolus should be given followed by continuous IV infusion. Any contraindication for heparin should be addressed. The use of thrombolytic in BE are gaining increase in use, and it is used only in hemodynamically unstable patient or right side heart failure. Clinical trials are still being done for the use of thrombolytic in BE. Other options such as IVC filter in patient who contraindicated to anticoagulation or recurrent attack regarding use of anticoagulation or right heart side failure can be done. Embolectomy can be done to remove life-threatening BE in hemodynamically unstable patient. To the second part of our lecture is Thromboendartectomy. It is a surgery to remove blood clot and scar tissue from arteries in the lung. It's called pulmonary thromboendartectomy or BTE, and it's also called pulmonary endartectomy or BAA. And it is considered therapy for chronic thromboembolic pulmonary hypertension. True incidence of chronic thromboembolic pulmonary hypertension is unknown. However, most experts agree that approximately 4 to 5% of all patients who have acute episode of pulmonary embolism. The disease is characterized by intraluminal thrombus organization and fibrotic scar tissue like stenosis. For surgical technique, there's a four basic principle in thromboendartectomy. First, endartectomy must be bilateral. Second, perfect visualization is essential. Third thing, identification of the correct dissection plan is crucial. Fourth, a complete endartectomy is essential. To the step, we will start by median sternotomy. Then the epicardium is incised longitudinally, then cardiopulmonary bypass with high ascending aorta cannulation and 2 Keffel cannulation. Then pulmonary artery vent in the midline of the main pulmonary artery. The patient is then cooled to 20 degrees. In this picture, you can see you can note initially that the surgeon stand on the left side of the patient. The left atrial vent is placed via the right superior pulmonary artery and directed into the left ventricle while the patient is cooling and the heart is fibrillating. As we said initially, primary surgeon to stand on the patient left side and preform on the right side. The approach to the right pulmonary artery is made medial, not lateral to the superior vena cava. Once the core temperature has reached 20 degrees, an aortic cross clamp is applied and myocardial protection is provided. In this picture, you can see that the surgical approach to the right pulmonary artery is you can see the approach to the right pulmonary artery, and please note that the right pulmonary artery is approached between the aorta and superior vena cava and not lateral to the superior vena cava. A modified cerebellar retractor is then used to expose the pulmonary artery. Longitudinal incision is made in the center of the right pulmonary artery from beneath the ascending aorta out under the superior vena cava and entering the lower lobe branch of the pulmonary artery just after the takeoff of the middle lobe artery. Any loose thrombus, if present, is now removed. Once circulatory arrest is initiated, the correct plane appears barely white, smooth, and silky in appearance, and lies between the intima and media. It is rare for this to exceed more than 20-minute period for each side. In this picture, you can see that the plane of the section is raised posteriorly and initially, and then a complete endarterectomy is performed. The endarterectomy is then performed with inversion technique because the vessel is everted and the subsegmental branch are being worked on. It is important that each subsegmental branch is followed and freed individually until the end. Then the surgeon moved the patient to the patient right side. A pulmonary arteriotomy is made slightly lateral to the pulmonary vent site and extend to the precardial reflection. Care must be taken to avoid injury of the left phrenic vein. The heart is wrapped within cooling jacket and retract using a mesh-like jacket, mesh-like basket retractor showing in figure 4. In this picture, you can see that the surgical approach to the left pulmonary artery. The heart is retracted medially using a net-like retractor, and the left pulmonary artery is exposed. The left side dissection is virtually analogs in the respect of that accomplished in the right side. After completion of the endarterectomy, cardiopulmonary bypass is reinstituted and warming is initiated. If other cardiac procedures are required, such as coronary artery or mitral or aortic valve surgery, these can be performed during systemic rewarming period. The most common procedure is closure of foramen of valve, followed by coronary bypass surgery. When patient has fully rewarmed, the cardiopulmonary bypass is discontinued with a successful endarterectomy. Surgical classification, there is a fourth level of occlusive disease. Level 0, no surgical evidence of thromboembolic disease. Level 1 indicates that obstruction involves one of the main pulmonary artery. Level 2, the fibrous tissue start at the level of the lobar branch. Level 3 is distal and start at segmental branch. Level 4 starting at subsegmental branch. Only this represents the most challenging patient. In this picture, you can see the surgical classification for the occlusive disease. Outcomes: in majority of the patient after successful surgery, post-operative hemodynamic value become normal, near to normal. Although most patients enjoy a significant improved hemodynamic state and improved functional class, residual pH after surgery remain the most important cause of early post-operative morbidity and mortality. In conclusion, surgical removal of thromboembolic material by endarterectomy is provided an opportunity for relief from this fatal disease. Although it is technically demanding for the surgeon and requiring careful dissection, but it is excellent for the short and long-term result can be achieved. The newly designed instrument allow better visualization and more complete endarterectomy in the distal, segmental, and subsegmental branch, will shown in figure 6 next. Educating physician and training surgeon to master the technique should remain a priority in treatment of this disease. In this picture, you can see the instrument used during pulmonary endarterectomy. These are my reference. This was the end of my presentation. Thank you for listening. Any question, please?
يعطيك العافية دكتور زياد.
الله يعافيك.
طيب, I just want to add one thing or asking one thing. Do you know the indication and contraindication for the surgery? Yani when we will take the patient, which patient we will take for this kind of procedures?
Yeah, you read about that for factor to take patient to surgery is the residual pH and the severity of the occlusion. But as indication, as far I know, it's the only pulmonary hypertension. Chronic pulmonary hypertension is indication for this procedure. As contraindication, I don't know actually.
تمام. الcontraindication اللي هو إنه يكون advanced age, prolonged CPR after arresting, when the patient having a comorbidities or frailty of the patient.
Yeah, perfect.
Is there any questions from the audience? تمام. يعطيك العافية دكتور زياد.
Right.
طيب, I think we'll take 10 minutes or we can start the next lecture. دكتور فراس.
ايوه
كيف حالك؟
خير الحمد لله.
You ready to go? I think Dr. Mazen will supervise.
He'll try to come. So apologies. He had an urgent case. I think he most probably will not come.
That's okay. You ready to go?
Yes.
Okay. Mic is yours.
Okay. Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. So today's journal club will be titled Assessment of Long-Term Outcome, Aortic Valve Reimplantation versus Aortic Valve and Root Replacement with Biological Valves Conduit in Aortic Root Aneurysm with Tricuspid Valve. So my name is Firas Fatani, R2 Cardiac Surgery in King Abdulaziz University Hospital. So outline of this presentation. I'll give some some points to remind the audience about cohort study, propensity score matching. Then I'll move to overview of the article and appraisal. Then we'll leave the last few minutes for discussion if there is anyone who wants to add points or has any questions. So cohort study comes from the Latin word cohort, a group of soldiers. So it is a non-experimental study that aims to find an outcome from a certain exposure. And it can be divided to prospective cohort and retrospective cohort study. And this illustrates the difference between both. In prospective cohort study, the researcher is looking for something for an outcome, and he will follow an exposure that already happened in the past, but he will the expected outcome will be in the future. Vice versa, in retrospective cohort study, both exposure and outcome has occurred previously. So cohort study is second to in the evidence-based hierarchy of evidence. It is second to randomized control trial, prospective being second, and retrospective being after prospective cohort study in level of evidence. The limitation for both the prospective cohort study is time consuming, and the retrospective cohort study has the measurements are not very accurate due to lack of selection, due to the exposure and outcome being already happened, and the researcher cannot put or follow the variable correctly or like he wishes. Propensity score matching. So it was introduced by Paul Rosenbaum and Donald Rubin in 1983. Both of which are well-known statisticians, one from Harvard University and the other from Wharton University. And it is a statistical matching technique that attempts to reduce bias and reduce confounding factor by accounting for covariance. So basically it is like randomization, but in non-experimental studies. The disadvantage of which it is only for accounted variables. So if the algorithm, if you put variables that are not so variables that are not put in the algorithm will not be accounted. So not all variable will be accounted in propensity score matching. So an overview, this research has is a comparison between two aortic root procedure, aortic root replacement, which is Bental and Di Bono, described in 1968. It used mechanical valve exclusively at first, but in the recent years, the use of bioprosthetic valve increased due to patient preference and risk of anticoagulation, and the hope for better outcome in the future in the valve-on-valve procedure. Valve sparing root replacement using reimplantation technique David procedure, introduced by David and Fendel in 1992 and evolved to David V procedure. The advantage of which is the preservation of native aortic valve leaflet and the less frequent reoperations. So the author stated that there is little data comparing the long-term outcome between DV and biobental operative approaches, and the previous literature was confounded by small cohort sizes, mixture of mechanical and bioprosthetic valves, and also the inclusion of cases with non-aneurysmal aortic root pathologies, aortic stenosis, and bicuspid aortic valve. So in this study, it aims to compare the long-term outcome between aortic valve reimplantation and aortic valve root replacement with biological valve conduit, focusing on patients with aortic root aneurysm and tricuspid aortic valve. So the indication for the operation was determined by the attending surgeon, and they followed the guidelines that were present at that time and still used currently. They used the European Society of Cardiology guidelines published in 2014 and the joint collaborated guideline between Aortic College of Cardiology Foundation and American Heart Association Task Force and American Association of Thoracic Surgeons and so on. So those were the guidelines followed in this study. And the guidelines were elaborated previously in this week presentation, in our weekly presentations by my colleagues. So the operative details for both procedure, David V technique was in brief. The skirt of Galweave Valsalva graft was used. And it was secured at the level of the nadirs of sinuses using 6-pledgeted mattress suture. The commissures were resuspended at 120 degrees apart to achieve good apposition of the leaflets. The remnant of the sinus tissue was reimplanted into a graft with a continuous double-layer mattress 4O sutures along the scalloped free margin. The assessment of the valve and valve repair was performed by visual inspection. Some surgeons started to use calipers. A primary cusp repair was added in 45% of patients. The biobental technique was as followed. Aortic root was trimmed. The proximal skirt of the graft was sewn to the annulus of the aortic valve with pledgeted mattress suture of 2O coated braided polyester suture. The proximal anastomosis was constructed with a single 3O polypropylene suture placed in a continuous fashion. They still implant with mattress suture if they were unhappy with the quality of the annulus. The result is a separate suture line to the graft proximal to the site of valve attachment. The left coronary artery button was then attached to the Valsalva portion of the conduit using 5O polypropylene running suture. And extra details can be found in the article or previous article that they published regarding their operations. So now to the appraisal. So the research question was a comparison, long-term comparison of outcome between aortic valve reimplantation and aortic valve root replacement with biological valve conduit, focusing on patients with aortic root aneurysm and tricuspid aortic valve. The population was patient with ascending aortic aneurysm who underwent surgical replacement at New York Presbyterian Hospital. The intervention was biobental procedure. The comparison was reimplantation procedure DV between March 2005 and September 2018. Both intervention and comparison were between March 2005 and September 2018. The outcome was long-term mortality. So the significance, so this, it is considered second most frequent disease of aortic, of the aorta after atherosclerosis, aortic aneurysm. The mortality and major morbidity of aortic root replacement have seen a dramatic decline in recent years. Refinement in surgical technique along with improvement in critical care led to that. Reports of elective operative mortality of less than 5% with marked decline in complication was seen in some centers. So all in all, research is like this that aims to find, to fine-tune and find the best surgical technique will help in the future. So there were no declared conflict of interest. So in comparison to the previous research in this topic, this study has a reported long-term outcome. It had a big cohort size, focused on patients with aortic root replacement and tricuspid aortic valve, and they excluded some confounding factor. We will talk about the inclusion and exclusion later. So design and attention to potential bias. So the main bias that will be found in such studies is selection bias, either due to surgeon preferences or to the sophistication of the operation itself, like in the DV procedure, which mandate a good selection. So this research was approved by the Institutional Review Board of Columbia University Medical Center with a waiver of consent. So inclusion, they included patients who underwent aortic root reimplantation and biobental for aortic root aneurysm with tricuspid aortic valve between March 2005 and September 2018 at New York Presbyterian Hospital. They excluded non-elective cases, patients with aortic stenosis, infective endocarditis, aortic dissection, previous prosthetic aortic valve, or aortic root replacement other than biobental or DV procedure. So the main confounding factor was the follow-up. We'll discuss that later. The follow-up in this research was not met. They mentioned that they will follow for 10 years, and the mean follow-up was 55 months, approximately 4 years, and up to 8 years. So they used electronic medical record for follow-up. The primary endpoint was all-cause mortality. Secondary endpoint were reoperation for any cause and aortic valve-related reoperation. Median follow-up was mentioned previously. So they met 80% of their expected follow-up. So the variables are baseline characteristic, operative details, and in-hospital outcomes. There will be a table discussing those variables. A continuous variable described with median and interquartile ratio, two-sided p-value less than 0.05 were considered to be statistically significant for all tests. So the baseline characteristic, these were the baseline characteristics. So as you can see before the propensity score matching, the letter B indicates that there were statistical significant age, baseline body surface area, coronary kidney disease, coronary artery disease, Marfan syndrome, previous cardiac surgery, and aortic insufficiency more than moderate was all clinically significant. But after propensity score matching, these baseline characteristics had no clinical significance. Operative details. So these were the variable used in operative details. As mentioned previously, there was no, before propensity score matching, aortic cross clamping, concomitant mitral valve procedure and CABG was statistically significant. After the propensity score matching, there was still increase in aortic cross clamping and there was aortic arch replacement was also statistically significant. In hospital outcomes, so before propensity score matching, all of the findings were in favor of DV procedure, with in-hospital mortality between in DV1 in Biobental 6, but after propensity score matching, the in-hospital outcome was similar. In long-term follow-up, so the survival was not clinically significant between both procedures after 10 years. In this Kaplan-Meier, the reoperation was clinically significant in Bental de Bono procedure with a p-value of 0.046. So the operative detail, there was significant difference remained, as mentioned previously, in cross-clamp time and concomitant transverse arch replacement. So these are the results. The in-hospital mortality occurred in 2 patients overall. One died of cardiogenic shock and one of, this is after propensity score matching, and one of respiratory failure with no difference between groups. There was no long-term survival difference at 10 years between the reimplantation and Biobental procedure. Incidence of reoperation for all cause was 4% in reimplantation and 20% in Biobental, and it was clinically significant. The reason for reoperation was, as mentioned in here, aortic insufficiency, 5 of the reoperation in Biobental, and aortic stenosis, and infective endocarditis. There was the patient who underwent 2 patients underwent transcatheter valve-on-valve procedure, and both had aortic stenosis. So the main finding was there was equivalent survival at 10 years between both procedure, and there was fewer reoperation in case of reimplantation. Follow-up of 10 years was not met in this study. So I finished my presentation. If there is any points or questions. So these are my references.
تمام يعطيك العافية. Thank you guys. I think we finish our academic activity for today. Have a nice weekend.
Okay, thank you.